Hi everyone, my name is Hannah Kopic, and today I'll be sharing my patient case study on multiple sclerosis, or MS. This case focuses on a 22-year-old college student who was recently diagnosed with relapsing remitting MS, which is the most common form of the disease. I'm going to walk you through her symptoms, how she was diagnosed, and her treatment plan based on current evidence-based guidelines. So before I get into the case study, I'm just going to briefly go over what MS is. Multiple sclerosis is an autoimmune condition where the immune system attacks the myelin that protects nerve fibers in the brain and the spinal cord. So this causes inflammation and scarring, which shows or blocks nerve signal transmission. Over time, this will lead to episodes of weakness, sensory changes, and vision problems. Early in the disease, the body can repair some of the damage, but as MS progresses, this becomes less effective and symptoms can worsen. Our patient presented to the University Health Clinic complaining of blurred vision, fatigue, and right leg weakness that had been going on for about 2 weeks. She first noticed it during finals week and thought it was stress related, but her symptoms started to interfere with walking and her ability to focus during class. She explained that it started with tingling and weakness in her right leg, which gradually worsened. Shortly after, she noticed some blurred vision in her right eye. She also recalled having similar episodes about 6 months ago that resolved on its own. She denied any fever, trauma, or recent infection, but admits she's been feeling constantly tired and unable to concentrate. These recurrent neurological symptoms are what led her to seek medical care at the clinic. She's not currently taking any prescribed medications, but she does take vitamin D daily. She reports a penicillin allergy, which causes a rash, denies any other medication or food allergies. She is not on any other drugs or supplements. There's no concern for medication interactions at this time. Our patient's otherwise healthy. She's got no chronic medical conditions or past hospitalizations. Her mom has autoimmune thyroid disease, which slightly increases her risk for other autoimmune conditions, including MS. She doesn't smoke, doesn't use recreational drugs, she drinks socially, and she's living a very active lifestyle. Her immunizations are all up to date, and she's been a full-time college student for the past few years. So I know this slide is kind of a lot, but when reviewing her symptoms, most areas are unremarkable. She denies any chest pain, shortness of breath, changes in bowel or bladder habits. Neurologically, she reports right leg weakness, tingling, fatigue, and an unsteady balance. Visually, she's had some blurred vision and pain with eye movement on the right side. Psychologically, she admits she's been pretty anxious about her symptoms and how they're affecting her schoolwork. She denies any depression. Overall, her symptoms are concentrated in the neurological and visual systems, which helped us to narrow our focus during the assessment. For her physical exam, she's alert oriented, appears a little bit tired, but no acute distress. Her vital signs are all stable. Neurologically, she just has some mild weakness and spasticity in the right leg. She's got brisk reflexes and a positive Babinski sign, which all kind of point to an upper motor neuron issue. Her right eye shows nystagmus and decreased visual acuity. Her optic disc also appears pale, consistent with optic neuritis. Her gait's slightly unsteady and spastic, which aligns well with the early neurological findings we'd expect in multiple sclerosis. So to confirm all the suspicions, I would have ordered several diagnostic tests. The brain MRI showed multiple periventricular and juxtacortical white matter lesions, and the spinal MRI revealed hyperintense T2 lesions. Her lumbar puncture was positive for oligoclonal bands showing immune activity within the CNS. Evoked potentials testing revealed delayed visual response, confirming optic nerve demyelination. Routine labs, including ANA, ESR, and B12, were all normal, which did help rule out lupus and metabolic causes. So altogether, these findings do meet the 2017 McDonald criteria for relapsing remitting multiple sclerosis. So just to summarize, for our problem list, her main clinical concerns: she's experiencing blurred vision in the right eye, right leg weakness and spasticity, and persistent fatigue that impacts daily function. Imaging did reveal white matter lesions on the MRI. Her CSF results confirmed oligoclonal bands, indicating inflammation in the CNS. She's also experiencing emotional stress and anxiety related to these symptoms. Together, these findings do point strongly toward a central demyelinating process consistent with multiple sclerosis. When developing the differential diagnosis, I did consider several other conditions. Neuromyelitis optica, I ruled that out because her antibody test was negative. Systemic lupus was ruled out with a negative ANA. A stroke did not really fit her presentation or any of the imaging that was done. Based on her history, the physical findings, the test results, my primary diagnosis is the relapsing remitting multiple sclerosis, which is the most common subtype and typically presents with discrete flare-ups followed by partial recovery. So my treatment for MS would focus on managing both the acute flare-ups for her and long-term disease control. For acute flare-ups, I would give her IV methylprednisolone for 3 to 5 days to decrease the inflammation and shorten the recovery time. Long-term management would include starting disease-modifying therapy such as acrelizumab or interferon beta-1a, which do help reduce relapse frequency and it will delay the progression of the disease. Supportive measures include physical and occupational therapy, stress reduction, and maintaining vitamin D supplementation. Our patient's going to follow up with neurology every 3 to 6 months, and she would undergo annual MRIs to monitor the disease activity. Managing MS requires strong community and emotional support. I'd first refer her to the National Multiple Sclerosis Society, which offers education. They have peer groups, and they do also have financial aid, which is really cool. The MS Foundation and MS Association of America provide equipment assistance, wellness programs, counseling services. She can also work with the Campus Disability Services for academic accommodations or college counseling for emotional support. These resources are essential for maintaining her independence and improving her quality of life while she is in school and then even beyond then. And here are my resources for this case. Thank you all so much for listening.